So thank you so much for the opportunity to present today. When I was asked to present on the future of newborn screening, my immediate thought was, well, this will be easy. I'll just put up a slide with a question mark and call it a day. But as Annie mentioned, over the past couple of months, as we've really navigated these uncharted waters, it has become clear that there is a lot of opportunity. And I know Annie mentioned that as well. That there is an opportunity to chart a new and better path for newborn screening. And this will largely, thank you, be accomplished through advocacy, which of course is not new to the world of newborn screening because newborn screening exists today because of advocacy. Advocacy from parents, from clinicians, and scientists. So as many of you may know, the first disease that we started newborn screening for was PKU, or phenylketonuria. And the discovery of that condition actually was in 1934, and owing to a mother in Norway who was relentless in trying to understand the cause, the underlying reason why her children had an intellectual disability. And this led to the discovery of PKU as a disease. Approximately 10, 15 years later, we now have a mom in the UK who has a child. She knows this child has PKU, and she is not okay with the idea that she's being told there's nothing that can be done. So she relentlessly pushes her clinician to discover a treatment, and that led to the discovery of the use of a formula that has phenylalanine removed to it. We call it fee-free formula, which is still a lot of how PKU is treated today. And then we move kind of later in that decade across the pond to the US, where now we know about a disease. We know that we can treat this disease, and we know that treatment is better when it is done pre-symptomatically. And so we have clinicians and physicians and scientists who discover a way to screen for this disease so that all babies with PKU have an equal chance for better health outcomes. And that was the start of newborn screening in the United States. And newborn screening, as we know, over the past 60 years has really grown into an incredibly complex system that spans numerous areas, from the health departments that do the screening, of course, to clinical arenas, to policymakers. But at the center is you, families, and patient advocacy organizations. And so for the rest of my talk, I want to focus how we at the center can really shape the future of newborn screening. And there are, as Annie mentioned, a lot of paths being discussed right now in newborn screening. And I want to note that you all belong at that table where those decisions and those discussions are being had. And so I'm going to use this kind of table idea as our framework, leaning on the wise words of Shirley Chisholm, who, if you don't know, was the first Black woman to be elected to the United States Congress. And she said, if they don't give you a seat at the table, bring a folding chair. And so for today, our folding chairs are going to spell out the word aspire, which are all areas: access, screening, policy, innovation, research, and equity, where we can make a difference in the growth and future of newborn screening. And so we'll dive into each of these for the remainder of the talk. So let's start with access to newborn screening. We're very lucky here in the United States that every state and territory does have a newborn screening program, but that's not true in all countries. And that's not always, the newborn screening programs aren't all the same across the states either. And so when we think about newborn screening, we think about how it fundamentally changes the patient journey. So on the left is a patient diagnostic journey, which is probably unfortunately familiar to many of you, where you have a child who starts with symptoms. You might go to your primary care provider, maybe some testing is done, maybe they don't believe anything is wrong yet. So then you go to Google and you start looking, you do online research, and you're looking, and maybe you get to specialty visits. Maybe they do more testing. Maybe they just treat certain symptoms. You go to more specialty visits. Maybe you eventually get genetic testing. And by this year, it can be anywhere from 3 to 10 years, and you still don't have a diagnosis. And at that point, maybe if you're lucky and you get your diagnosis, it's often too late for treatment or clinical trials. But on the right, if we look at the newborn screening pathway, the idea behind this is that right away, between 24, 48 hours of birth, we can identify a child who is at risk for having one of these conditions. At their first visit to their primary care provider or their specialist, we can do confirmatory testing and we can get a diagnosis within days to weeks, which opens up all of these new treatment options and participation in clinical trials. And so this is what we talk about when we talk about why access to newborn screening is so important in reducing diagnostic delays and increasing access to novel therapies. And again, newborn screening in the United States is everywhere, but it is not equal. And so we also, when we're thinking about access to newborn screening, we have to think about equal access. This is a map of the United States that shows on a gradient the number of conditions that each state is screening for that is on that core recommended uniform screening panel. And you can see that it's essentially 50 shades of gray or green. If you think about that, that means that some babies are screened for some conditions and other babies are not screened for these conditions. And so this is a really important place of advocacy within newborn screening, is to standardize the panels that are being screened for. And one of the reasons why that Federal Reauthorization Act is so important, and I'll touch on that later. So for each section, I was thinking of ways to tangibly provide ideas of how you can get involved. I know sometimes when we think about advocacy, we think about it as this very formal type of approach, and you have to go to an event and it has to be in DC and you have to have media and you have to come from money, and that's just not true. There are so many ways that you can be an advocate in this space across the spectrum. So when we think about increasing access to newborn screening, we can become things like equity architects, pushing for these universal policies that eliminate these geographic discrepancies. Community translators, tailor your messaging and materials to meet the linguistic, cultural, and literacy needs of all families so that all families can engage and think through this. Policy mobilizers, champion legislation and funding that supports infrastructure, workforce capacity. This is a big issue for us in newborn screening, and the follow-up services that we need after newborn screening testing is complete. Be trust builders. This is a big issue for us in newborn screening, and the government really in general is being trustworthy. And so fostering relationships, helping connect the dots between communities that have been historically excluded or harmed by public health systems, getting them more engaged in fostering trustworthiness amongst public health communities. So let's move to screening itself. One of the big things that we are thinking about in newborn screening right now is the expansion of our panels. And expansion is becoming more and more of a consideration for us because we have both new technologies that allow us to test for more and more diseases. And we have therapeutic advancements that are now converging that mean more and more diseases are going to make sense for newborn screening. We're going to have a test, we're going to have a treatment, and we're going to need pre-symptomatic detection. At the same time, state newborn screening programs have very little resources right now. We are lacking the sustainable resources needed to keep pace, to add more and more conditions and use these new technologies and provide these new therapies. And so as we're thinking about how to advocate for screening, I want you to really think about not just advocating for adding the test, but advocating for the funding that goes around the entire system. Cost to newborn screening goes well beyond the cost of the test. I think sometimes we see, oh, it'll only cost 10 cents a specimen for us to add diseases, and that's generally not true. That's just the cost of the reagents, maybe the equipment, but there's a lot of other things that go into testing, and more importantly, the support of the families that we find that we need to think about. And I do want to highlight one thing here. So I believe Dr. Munzer yesterday appropriately indicated that in most cases we are fee-based in state fee newborn screening programs. That's how we operate. However, much of the work that we do in terms of expansion, in terms of adding new diseases, is actually federally funded. and this is at risk right now. And so we have to think about also advocating for funding, maintaining our federal funding to newborn screening programs as well, despite the fact that we do use a fee-based model for testing. So in terms of being an advocate for screening expansion, you're going to start to see kind of a lot of common themes as I talk about these. I'll just focus on ones that are different. Stakeholder weavers. Really important for us to connect researchers, clinicians, policymakers, and families so that we are co-creating our expansion strategies that are grounded in our shared values. I think we all have the shared values of wanting to find these children, but acknowledging the limited resources in the ecosystem that we're in there and making sure that any expansion strategy supports that. I already mentioned the need for funding, so being funding champions, advocating for a sustainable investment in infrastructure that may be asking for an increase to the newborn screening fee to cover things, especially in light of federal funding uncertainty right now. And then I want to really earmark global connectors. One of the things that we're seeing more and more in newborn screening is the use of global data to support the addition of newborn screening diseases to newborn screening panels. For example, as we've been working through metachromatic leukodystrophy, we're relying heavily on German and Austrian data. As we think about some of the MPSs, we're likely going to use a lot of Taiwanese data. So this global connection is so important, even if we're focused on US-based newborn screening. So policy, let's move to policy. And luckily, Annie is amazing and set me up so I don't have to go through this as much, but policies in newborn screening are needed for a number of reasons. We've already talked about funding, adding new diseases, addressing issues of access, treatment access, diagnostic access, thinking through things like genetic privacy and the use of the dried blood spots, many reasons why policy is important in newborn screening. And because newborn screening programs operate at a state level, most policies around newborn screening are state-based. So we're really talking about working with your state legislature. That's often how diseases can be added and funding is set. There's also, most programs have newborn screening advisory committees. They're often the ones making recommendations on policies and operational procedures for programs. These are typically public meetings where either you can attend, you can make public comment, or you can even join as family members. Though newborn screening programs and most policies are at the state level, as Annie mentioned, there are federal policies that can and do impact the newborn screening system, which of course is the Newborn Screening Saves Lives Act, which Annie referred to. This not only has been stagnant and expired now for 6 years, since 2019, we did recently have the dissolution of the Federal Advisory Committee that oversaw the addition of diseases to the Federal Recommended Uniform Screening Panel. I will say that there is significant work being done around this right now. You can see that there have been calls for questions on why this committee was disbanded, how we can move forward, and the need for continued federal oversight. The reauthorization bill act was also reintroduced, and so there remains hope that we can bring some of this federal oversight back to the newborn screening system. So in terms of policy, ways that we can support policy, and I think Annie did a beautiful job of this, so I won't belabor it too much, but I want to focus on a couple of things, which are the narrative strategists. Annie said beautifully the kind of confluence of data and storytelling is so important. So finding a way to share your story and humanizing the data really is a way to spotlight the lived experience and turning statistics into a sense of urgency and putting a face on this data. And momentum makers, so keeping things like newborn screening on the legislative radar. So there are coalitions that are involved. Every Life Foundation takes a huge leading role in this, getting involved in those coalitions, involved in public engagement campaigns as well is really helpful to sustain our progress. So let's talk a little bit about innovation. And we can't talk about innovation in newborn screening without talking about genomics or whole genome sequencing, which is a very hot topic right now. And many people feel that genomic newborn screening offers this unparalleled potential for early diagnosis and intervention because it allows for screening for a large number of diseases at once. There are a number of pilot projects going on in this space right now to look at the feasibility of doing this. The NIH actually has a proposed project that should be awarded shortly to look at whether genomic sequencing can be integrated into public health programs. But this is definitely a hot topic in newborn screening around innovation. Further understanding just in general that a program that is now 65 years old inherently needs to modernize and evolve. We are in a much different place from the 1960s when newborn screening first occurred in terms of technology, ethics, equity, access, general concerns around privacy and comfort with government programs. And so the National Academy of Science, Engineering, and Medicine recently put out a report calling for ways for modernization of the newborn screening program. It is free to look at. It is a wildly long document, so have some popcorn and wine with you. But it's a interesting read in terms of how they are envisioning modernization, and there's some great ways I think that advocates can get involved to make that happen. So how can we accelerate innovation in newborn screening? You'll see kind of some of the same things over and over again. The narrative, storytelling, storytelling, storytelling is so important. Also be an innovation scout. I think none of us have all the time in the world to identify some of the emerging tools, models, understand where the unmet needs are, especially in rare diseases. And so where do we need to find innovation? What is available out there that we might be able to leverage within a population public health program? Great ways to think about advocating for innovation in newborn screening. Research. So most of the time when we think about research in newborn screening, we're thinking about what we call pilot studies. Pilot studies are designed to essentially provide us as programs data on kind of different parts of the system. Do we really fully understand the clinical characteristics of a disease? In most cases, we often know a lot about the severe forms of the disease and less about the milder forms of the disease. Pilot programs can kind of help us delineate that a little bit more. Can we even do this in a newborn screening system? Can we do it in a very high throughput, high quality laboratory screening kind of platform? Are we doing it in a way where we are finding everyone we want to find, but not having too many false positive results? Can we do population-based screening? Can we get these children into diagnosis? And can we get access to treatment in a timely way? Are there any benefits? Or what are the benefits and harms to the infant screened as well as family members? And there are a ton of other research needs in newborn screening. I'm not going to go into these. And again, I think you'll have access to these slides, but it doesn't all have to be bench work. It can be how were the results communicated? Were they effective or did they scare everyone involved? What are some of the costs associated with newborn screening? What are some of the ethical components? What do we think about with integration of genomics? There's a lot that we can do and need to do around research and newborn screening. And so in order to support research, again, there are a number of things that we can do. And you'll see the word story amplifier here again. So I'm not going to talk about storytelling, but it holds true across everything. But being priority shapers, help influence research agendas, help us understand where we should be putting our time in research. What are the most pressing needs from you as a family who's either experienced the diagnostic delay clinically or experienced newborn screening? Being trust brokers and data governance stewards as well. This again in research, we need to foster trustworthiness and we need to build bridges between researchers and communities, making sure that we're transparent and culturally humble as we work with all of these different populations. And finally, we've come to the end of our Aspire framework, which is equity. And this is really a passion for me in newborn screening, because I think sometimes we mistake the idea of newborn screening being universal as being equitable. And universality and equity are not the same. So we do see disparities across the newborn screening system, whether that is in research and clinical trials that happen upstream of newborn screening. There our equity and disparity issues and abilities to advocate across different resources, across different disease states. We see disparities in the way we do some of our testing, and certainly we see disparities in access to follow-up and treatment afterwards. I think it's important for us to realize that while we'd like to think that the pathway from newborn screening to early and timely accurate diagnosis and treatment is straight, it's not. It's just not. We live in a country with a interesting, I'll say, that's a very Midwest way, criticism is, that's interesting, interesting healthcare system where there are a lot of things that need to be overcome within the healthcare system in order for us to actually meet the promise of newborn screening. And so thinking about how we can help these families navigate what is arguably a very complex maze of geography, systems of oppression, mistrust, language, health literacy, insurance, et cetera, to get to our goal of that accurate diagnosis and early intervention. So I'll end before passing to our final speaker on ways that we as a community can come together to increase equity. And the first one I'll say is looking at being a gap illuminator, using data in your stories to expose where there are disparities in access, outcome, follow-up. Make sure that we are talking about these and that they are visible and heard. We cannot address things that we haven't assessed. And so telling your story and when things went wrong, no one likes to hear when things went wrong, but we can't make it better if we don't know that things didn't go well. Be community anchors, building trust. And I think that's one of the beautiful things that MPS Society does is building this trust through sustained engagement and really honoring the lived experience and becoming an anchor for the community as they walk through a lot of this journey. And of course, you'll see the last one, the storytelling. And I know we're going to highlight that later as well, but storytelling is such a beautiful way to start your advocacy journey. It is so powerful and an easy way to just share what's going on and make sure that people know what you're going through and what our needs are. So with that, I'll pass it back to Stephanie.